for that, Graham. And it's wonderful to be here at a personal level, having grown up and trained and having seen, I suppose, lots of inspiring names as I was going through GP training and who are here in the room. And here I am today as one of the representatives of the Deep End Ireland team. So I'm the unlucky one who's been pitched up as the spokesperson for this presentation, but there's lots of people here in the audience from Ireland, and we're delighted to be here. So the Irish context is complex and quite different to what we've been discussing for quite a lot of the last 2 days. So just to give you a very, very brief explainer. So we have quite a mix of public and private when it comes to general practice and primary care. So about 1/3 of our population are entitled to opt into this system known as the GMS, or the medical card system. And generally in the practices in deep end areas, most of our patients would be medical card patients. The other 2/3 are expected to pay out of pocket or would have insurance. A GP gets an annual capitation payment based on the age of the patient. It doesn't matter if they're from an affluent area or from a deprived area. It's the same amount. It's done by age, and there is no deprivation waiting in that. Other people, as I said, pay for each visit. Those with that medical card, on the face of it, have access to outpatients, have access to procedures, have access to investigations, have access to multidisciplinary therapies. But in truth, the public system, as it's known, is thoroughly under-resourced, and there's very, very long waiting lists. There's queues for investigations. We often, say for MRIs, we would have to go through orthopedics or through the hospital clinics, and you could be waiting 1 or 2 years for an outpatient's appointment for one of those clinics. Similarly for physiotherapy, speech and language therapy, we have huge waiting lists. So obviously that, with this public-private mix, and the model that we have, it perpetuates the inverse care law, and we see that on a daily basis. GPs are not employees, they're considered private contractors, and so they have this GMS contract on a patient-by-patient basis with the system to provide care for that patient. But during the recession, there was a 38% cut to all of those capitation payments, and this hasn't yet been rolled back. And hence, however many years later, we were on the streets last week or 2 weeks ago protesting as GPs to say we want these cuts that were imposed on us during the recession, when they've been rolled back for pretty much everybody else in the public service, but haven't yet been rolled back for us. And it's become a bit of a bargaining chip in the negotiation of trying to fund and provide general practice care in Ireland, and it's just dragging on and on. So there has been wider underinvestment in health and primary care in particular across the last number of years. We have lots of crises in waiting lists in hospitals, in waiting times in the emergency department. We have our most recent crisis is the spiralling costs of our new National Children's Hospital, and these crises tend to take a lot of the focus and suck up a lot of the money in the health system, so we're left kind of at the periphery. So the picture we're painting is general practice and primary care in general has underinvestment. General practitioners across the board in all areas are suffering from these cuts. And obviously us in the deep end who depends, I suppose, proportionally so much more on the medical card system, because we don't have that many private patients in our practices, are kind of at the mercy of this. Needless to say, this affects recruitment and retention, and Austin's going to speak a little bit about that next. Recruitment and retention is really, really difficult in general practice. It's difficult across the board. So you can imagine in areas of deprivation and in deep end practices, it's less appealing again. The contract negotiations have been ongoing. I graduated in 2012 from GP training, and at the time, the existing contract was described as not fit for purpose, and there was talks of negotiations starting. So these have been dragging on and on and on. There is some light in things like Sláinte Care, which was a cross-party committee initially that reported in 2016 looking at the future of healthcare in Ireland. And I suppose that was within the time that we have been organised, and we actually fed into part of that. So in that Sláinte Care report now is mention of the inverse care law, and submissions by Deep End Ireland, we would like to think, contributed towards that. So it's a pretty bleak picture. So we're working at I suppose, a level of trying to, the points you were making there about kind of not clashing with other GP colleagues who are working in affluent areas, you know, we definitely, I suppose, try and work and collaborate, and the unions that we're I suppose, dealing with and negotiating with are covering all GPs, not just us in deprived areas, but we definitely have greater need, and that's why we've organised. As Graham explained, Edel, and a group, I suppose, that began in Dublin, aiming to share experiences, and it was, I suppose, a case of kind of finding your tribe. People were attending CPD meetings for the general GP population that just weren't hitting the mark when it came to, you know, the number of kind of child protection issues we would see in a week versus other practice in dealing with migrant health, lots of issues like that, addiction, homelessness, all of these things that we would see, and that we weren't finding that the general CPD was meeting our needs. So we contacted Deepend, the group in Glasgow. One of the ongoing issues we had, and still do have, is identifying who is Deepend in Ireland. There is no deprivation payment, there is no obligatory registering with a practice, so, you know, patients move all the time, so it can be very difficult to define what is a Deepend practice. So that's been a challenge we have ongoing. We had our first formal meeting in 2012. Like I said, it was before my time with Deepend Ireland, but Petra was over to speak at that. Since then, we've had regular committee meetings, CPD meetings. We've had engagement with our college, the Irish College of General Practitioners. We had a formal launch meeting in 2016 where Professor Watt came to speak. And that really was bringing GPs from across the country who were considered themselves to be working in Deepend areas, and to brainstorm, I suppose, to describe the model that existed here in Deepend in Glasgow and other places, and to see, because of our, I suppose, unique circumstances with the context, what we needed, what we wanted. It wasn't hugely different to what has been explained and what's been happening in the Deepend in Scotland, and a lot of it was down to collegiality, feeling that there's other people there in the trenches doing this work. To be able to talk about it, but also to be able to feel like we were doing something beyond the individual consultation to try and improve things for our patients. And that's carried through. We had an annual meeting in 2018 where our focus was on links workers, and Maria Duffy, who we met again yesterday, came over to speak, and we focused on that. Moving forward, our campaigns, obviously we're there constantly. Even this week, Susan and Adele we're meeting with some of our unions who are negotiating the contracts to try and get them to understand on a daily basis what it means, and the potential of hopefully having something along the lines of a deprivation payment, but to have that written in, to have recognition of it. We focused at our last meeting on links workers, and to see if that could be discussed or negotiated. This year we've taken, and it chimes with what you were saying about the children in poverty, and our focus in 2019 is going to be children in poverty at our Deepend meeting. So it's about bringing together experts, bringing together our experience, and trying to progress that. We engage with the unions. We have I suppose, two unions that cover us mainly, and trying to discuss with them our needs, trying to get them to understand. We have made presentations to the Oireachtas, our parliaments, and their health committees, the Committee of Future for Healthcare. We've been meeting with TDs locally and nationally, and I don't know if any of you have ever actually been to a TD or parliamentarian's clinic. It's a bizarre place to be in a waiting room and sit. But I learned a lot that day. So it's about going, meeting our local representatives, but also our national representatives, meeting with the Minister for Health, meeting with the officials behind it, meeting with the people in charge of this Sloan Care project that's happening. So we're doing that. Media engagement, letters in the Irish Times, discussion around these issues, and I suppose bringing in the Deepend experience in issues like child poverty, and we've had a focus as well on mental health and child and adolescent mental health, which is a massive, massive issue for us at the minute. We've had a number of annual reports as well. Sorry, that was back the way. So recommendations, they may seem pretty basic in comparisons to what's been explained already. We're hoping and aspiring. We have primary care teams, multidisciplinary primary care teams, but they're in a haphazard manner. They haven't been developed as they were, I suppose, envisaged, but we see them and feel they would really, really be crucial to the areas of disadvantage that we work in. but the problem is, staffing of them. There tends to be quite a throughput of the healthcare professionals on these teams, because these areas are considered quite difficult to work in. In the primary care team I'm on at the minute, we have 1/3 of a speech and language therapist full-time equivalent. So she's covering 2 other sectors as well as ours, and is totally swamped and under-resourced. So it's just trying to get the system and the guys in the Department of Health to understand that we actually should have more of that speech and language therapist time rather than less. Strong primary care infrastructure, and that can be primary care centres acting as hubs to facilitate linkage with the community, to allow discussion, to allow clinics in co-location, and to foster energy around that. GP supports, including more consultation time that's been discussed. Simple thing like deprivation-weighted capitation payment, salaried GPs, and again that's controversial in some parts. Salaried may mean being actually funded or directly paid by the government or otherwise, and it's not something we're used to in Ireland. But we're thinking of areas of deprivation where we're struggling to find GPs. So we're trying to think outside the box and cleverly about this. But additionally, we know we're part of a team. Practice nurse time, admin time has been mentioned as well. It's hugely important in our practices. And then, like we said, improved access to diagnostics and other secondary care services. So instead of us being actually waiting longer with our patients with multimorbidity and who have higher rates of morbidity and mortality than the other socioeconomic groups, we feel we need access. So we've said the challenges: health system, contract uncertainty, difficulties identifying who we are. We know what we want, but geographically we're spread as well. For example, I'm based in Limerick, we have colleagues in Cork, and the bulk of the group are in Dublin, so we're kind of learning to get around that with teleconferencing, CPD meetings, and doing that. The future is not all stark and dark. It's there is still high public satisfaction levels. We are at the centre of our communities in deprived areas. We have quite an understanding of our patients from cradle to grave in a way that I never imagined when I finished medical school or GP training, in fact. The Deep End Ireland numbers are growing, and I suppose there's great understanding among our colleagues of what we are doing with the profile of the group. And we see these new contracts and Sláinte Care as possibilities for us as well. So that's it. And thank you very much.